So, Monica, shall we wait because there are only 12 participants? They are here and rest probably joining.
No, I suggest you to start at this point, yes, in case they will join us later.
Okay.
Okay, so enjoy the session, and Yazir, thank you so much again for your time and availability.
You're most welcome. And thank you for giving me this opportunity to share some experiences from the field. So guys, thank you so much. It's pleasure meeting you all. So as Monica has introduced that I'm Yasser, I'm a PhD student year one. I'm basically from Pakistan and working in since last 18 years in healthcare and with special focuses on public health, maternal, neonatal and child health since last 12 years. And I have been working in Pakistan, especially in urban slums, for under this particular thematic area where I developed my skills in research as well as implementation in the field of MNCH with specific focuses on pregnancy, risk certification, nutrition, as well as immunization programs. So my topic is basically to introduce you guys the key concept of maternal, neonatal and child health, and then linking it with the disaster and to get your and to help you guys get oriented with this key concept. And you will learn at the end of this session that why this maternal, neonatal and child health is a key topic in global health and as well as in humanitarian and disaster medicine. And as you go further, you guys will understand this. But make this session interactive, please. This is my humble request. If you have any question, if you have any comment, you don't have any clarity on certain slide or anything which I have spoken, so please do raise your hand and do share your concern so that I can explain it in a better way. And I will try my level best to build this concept as clear as possible. So as you guys know that this topic will entail maternal, neonatal and child health in disaster. So before we enter into linking it with disaster, it's really important to understand what actually it entails this particular area of global health, maternal neonatal, MNCH, which we call. So MNCH is the key term which you guys will probably have heard or be listening a lot in your next career path if you will be joining public health or even if you are really in clinical. So definitely MNCH is going to be the key things. So I'll be happy if you guys will also turn on your cameras so that I can see who is here, who is talking. So that will be super helpful to see you guys because this is online session. So we have to take this leverage of connecting with each other through these cameras and not switching it off. So I'll be very happy if you guys switch it on. Even doesn't matter where are you, whether you are in car, you are in cafe, hospital, wherever you are, it doesn't matter. Would love to see you guys because sometimes it's also happened to us that we are in weird situation and we have to open our cameras. So please do that. So this topic of today's topic will cover some key concept. First, to build an understanding and knowledge about population dynamic in the context of MNCH indicator. MNCH, as I mentioned, maternal, neonatal, and child health. which abbreviated as MNCH. And then MNCH during disaster with a specific focuses on potential delay in care for pregnant women, nutrition in emergency, universal immunization coverage, and universal health coverage with its specific target on primary healthcare and access to care. So, maternal health in nutshell. If we really want to see why maternal health specifically, so you can see from this slide that why it is important, why so much focuses on maternal and child health. Just for your information, that most of the investment so far has been made in the field of global health research, country level budgeting, financing of healthcare. Most of the money goes to maternal, neonatal, and child health. This is the key area. And why so much investment, and why so much worry, why so much importance to be given to this particular population, maternal and child. You can see from this slide that every day approximately 810 women die each year. This figure is the most updated figure. So nearly, still we are in 2020. This figure probably be more worsened because of COVID related challenges and also some global humanitarian challenges. But almost similar number of women died each year, each day, due to preventable causes. When we say preventable causes, you guys will came to know this particular term, understand this particular term as well, that why we are saying preventable causes, because most of the women, they are dying, yes, but most of the causes because of which they are dying, they are easy to handle, they are easy to prevent, but still these many women die each year. And the most worrisome thing is that 94% of deaths are contributed by low and lower middle income countries, which is the most challenging. And you can see from this graph here, all these dark blue, bluish, and the greenish color, they are showing the most contributing countries. So you can see India, and some African countries, Pakistan, Afghanistan, and some Far East countries. They are contributing a lot to these maternal deaths, and all preventable, all can be averted with very basic interventions, with very basic health services, which these countries are deprived of. Or you can say most of the communities in these countries are deprived of those services, are deprived of the basic healthcare facilities. Coming to child health, so this is even worse. So remember, when we talk about maternal, neonatal, and child health, so remember one thing, that these are the two major vulnerable group in every population, and especially those who are under 5, like children who are under 5 years of their age. So you can see from here, approximately 5 million children die each year, or you can say 13,000, almost 13,000 deaths globally pertaining to this particular group, which is alarming. And the most alarming thing is 50% of all these 5 million deaths, they are all died before reaching, during their first month of life, like they born very soon. So this is when we when I was receiving the training, especially in this particular field of MNCH, and interacting with communities, interacting with primary healthcare centers, there was saying by those who are dealing with this kind of population that when the child born, the child risks start from there in low middle income countries, because now the child being exposed to all the vulnerabilities which actually are leading to the death of that child. So every day the child successfully passed, the chances of death become decreased. So for example, most of these deaths who are happening during first 4 weeks of life, the most of these deaths are happening at day 0, like when the child has born. And there are a lot of, again here, the causes, all majority of them are all preventable, which I will discuss with you in next couple of slides. So we can see here that more the importance of this particular vulnerable group has been linked to the number of deaths which are associated with them. So they are causing the burden on countries in terms of deaths. And that's why most of these children who are, you can see here also, where most of the maternal deaths are happening, the similar countries are also contributing to the child death as well. So the causes behind those child deaths, they are also very much preventable. They all are preventable. Majority of them are preventable, but it's still happening. So that's the reason why most of the developing countries have low life expectancy, because you can see here most of the children, most of the population group is dying before reaching the age of 5 years. So that's why country like India, Pakistan, and most of the African countries and Far East countries, they have lesser life expectancy, because most of the population group, they are dying during this particular under this particular age group. So how we are calculating this child death mortality? This is pretty much linked to the question which I have given to you. So you calculate it on an annual basis. Every country under WHO and UNICEF, they have their databases in which they have records for all the births, annual births. So out of those annual births, how many of children died in specific countries under the age of 5? So you calculated your numerator is the number of deaths under the age of 5, and your denominator is number of children born alive during this particular year. So you calculate the rates of child death as well as maternal deaths based on the annual birth cohort for each country or a specific district, a specific area where you are working, a specific locality, specific community. So it's very easy to calculate. So I have requested Monica to share with you guys these 4 questions in which I wanted to hear from you guys that what do you understand with this term of maternal and child mortality, which are the top 10 countries which are contributing the most to maternal and child mortality burden. What are the major causes of child mortality, which probably you are aware or you have searched. And the 4th one is maternal child mortality, specific to your country, province, where you are currently living. So if you guys have prepared this, so I am happy to hear from you what you have searched, what you have identified in terms of these 4 questions. So anyone can start, and then we can go further with the group. Yeah, sure, Inas.
I should answer the 4 or just one question?
So all 4 of them, no worries.
Okay. How do you explain the maternal and child mortality? The maternal mortality is death due to any complication during pregnancy or childbirth. And child mortality is, I guess, also death from any kind of disease or complication for any child under 5 years old. The top 10 countries, I have no idea about the contributing country, but I can just guess that maybe it's most probably the developing countries, since they have a problem in resources and vaccine infrastructure, etc. Maybe my country is one of the top 10, Sudan.
Where are you from, Inas?
Sudan.
Okay. Yeah,
Mm.
Sudan is among top,
Yeah.
top 20s. Yeah.
Yeah, I can guess that.
Yeah.
What are the major causes of child mortality? Well, I guess maybe the torch, the torch, communicable disease, or maybe if the mother is already living in developing country, maybe she cannot find the prenatal appropriate prenatal care. But again, I'm just guessing. I don't know the major causes, but this from my comprehension. Okay, what is the maternal and child mortality in your country and province where you are currently living? Yeah, as I mentioned, it's pretty prevalent here, the maternal mortality and the child mortality, because the healthcare services is not accessible um, in every place, especially if you're going far from the capital or from the countries to the countryside. They do not have very access to health, and also there is inadequate in resources in the health workforce, and yeah, they have lack in many aspects. So it does affect the situation of the maternal and child mortality. Thank you.
So just to share with you, the maternal mortality of Sudan is approximately 300 per 100,000 births. So on 1 lakh new births, at least 300 women die each year. So it's a significant significant mortality, and also in terms of child mortality, every year approximately 78,000 children under the age of 5 died in Sudan, which is also a significant number. So I will touch based on why children are dying, why women are dying, and also the causes of deaths pertaining to these deaths. I will share with you guys. So there is another hand raised. So go ahead, please.
For the first question, maternal and child mortality. For maternal mortality, it's usually due to a woman going to the wards due to pregnancy, and then maybe because of an unfortunate incident, the mother dies. And also child mortality can also occur through such means. And it can also occur through infectious disease like malaria, diarrhea, cholera, and others. And for the second question, I found some countries, and most of them are African countries which are developing. And so for the first one, I found Somalia to be the first, Nigeria to be second, Lesotho to be third, Chad to be fourth, DR Congo to be fifth, South Sudan to be sixth, Guinea to be seventh, and Mali to be eighth. But I didn't find the other two to make it up to 10. And this data was collected in 2020.
Okay.
And also the major cause of child mortality. What I found out was mostly infectious diseases like malaria and others. And also the maternal and child mortality in my country, according to a survey, it was recorded to be 44.7 deaths per 1,000 live births in my country. And it has been seen that from 1971 to the year 2020, there has been a decline from 201.4 deaths per 1,000 live births to 44.7 deaths per 1,000 live births. So it seems my country is doing a lot in helping to prevent maternal and child mortality. Thank you very much.
Where are you from? Sorry, where are you from? Which country you belong to?
Please, I'm from Ghana.
Ghana, okay. Thank you, thank you. So anyone else? So yeah, please, Natalie, please go ahead.
Hi, I'm from Palestine. And do you want me to answer all of them again?
Yeah.
Okay. So maternal mortality is any pregnant woman that dies of complications of pregnancy or 6 weeks after, and it's expressed per 100,000. And then child mortality is any child that dies only under the age of 5, and it's expressed per 1,000 lives. And the top 10 countries, just a second, they are Uganda, Tanzania, Ethiopia, Kenya, Mali, Nigeria, Congo, Chad, Afghanistan, Pakistan, and Ghana. And the source, it says the United Nations that I found. And the major causes of child mortality are premature birth, pneumonia, birth defects, and newborn infections, malaria, sepsis, measles, birth complications, and the last one says diarrhea. And the maternal and child mortality in my country, which is Palestine, the numbers that I found were for maternal mortality is 20 per 100,000 live births. But that was in 2014, and I don't know if there are any newer updates. And for child mortality, it was 16.5 deaths per 1,000 live births, but that was in 2020.
Okay. So thank you, Natalie. So another key aspect. So I will move further to other participants as well, but just to highlight one key thing. These maternal and child health mortality indicators, they are also tracking, they are also being used for tracking of country progress for over the year of investment which has been made by countries, by different funding agencies. So every year, all the countries' key indicators on maternal mortality and child mortality and causes of death are being tracked by WHO and UNICEF, and also by countries, so that they can understand that where each country is standing in terms of reduction targets for sustainable development goal, for example. And previously it was Millennium Development Goals. So every country has given the target to reduce the child mortality by a certain percentage, by certain numbers. So every country is being tracked by these indicators, that how many children are dying each year, is whether the country is on track, progressing slow, or stagnant, or moving fast toward reaching the goals. Just for your information, every country has signed or committed to Millennium Development Goals, which were specific for maternal and child mortality as well. But unfortunately, majority of the developing countries were either far behind or progressing very slow. There was a progress and is still a progress, but the progress is very slow compared to high income countries or middle income countries. So just wanted to share that. So please, anyone else, please go ahead who has raised a hand. Sorry for that. Few people raise the hand, and yeah, please go ahead. Raza, please go.
Hello. So I won't be speaking much since a lot of the definitions are already covered, and that maternal mortality is, death of a pregnancy, death due to a complication in pregnancy, or a month after pregnancy. And child mortality is basically the death of a child due to any complications within 5 years after birth. I don't really remember the top 10 countries at the moment, but I did search for them, and I do remember that most of them were African countries from, like, I think South Africa, South Sudan, Congo, and Somalia, and I guess middle income countries as well, could include Pakistan, India, and Afghanistan as well.
Yeah.
The causes of maternal child mortality, what I found was mostly based on infectious diseases, pneumonia and malaria, diarrhea, because most of these countries don't have a lot of good vaccination programs against these diseases. And also because of malnutrition of both child and the mother, and also some congenital defects. The child mortality in my country, so I'm from Pakistan. It's
You're from Pakistan.
yes.
Okay. Be careful then.
Yeah, the numbers are not really good. For the maternal mortality, it's about 320 per 100,000. So 320 deaths per 100,000, and for child mortality, it's about 50 per 1,000. So really grave numbers.
Which specific province you belongs to?
Sorry?
Where you live?
I'm from Koita.
Okay, so what's the child mortality in Balochistan and the maternal mortality?
Oh, there are no any specific functions. I mean, I did found some data on it, but those were really old, and there haven't been any recent surveys for this.
Just for your information, Balochistan has the worst child mortality, highest child mortality and maternal mortality, because most of the area in Balochistan, they are remote, services are not accessible. So highest mortality according to the recent National Nutrition Survey, as well as Pakistan Demographic Health Survey, which was conducted back in 2018. So Balochistan turned out to be at the highest side, both in terms of maternal as well as child mortality. And when you measure the coverage for different services like immunization, access to pregnancy care, as well as child-related care, so those indicators are also really poor. So yeah, Balochistan has the worst maternal and child mortality. Okay, so thank you, Raza. Anyone? So there are quite a few people who still have to share. So please do that, or I will call the names, which I don't want. Jasmine, do you want to share what you have explored? against these questions?
Hi, yes, I can have a bit of a crack at the questions. So I think we've already covered a lot of like the definitions where we're repeating each other, but like in Australia specifically, I'm from Australia, by the way. In Australia specifically, we have a very low level of maternal and child mortality because our healthcare system is very well developed. We have both private healthcare and public healthcare, so no one really falls through the cracks. And so where in Australia, our child mortality rate is about 3.7 deaths per 100,000, per 1,000 live births. And our maternal mortality rate is about 5 mothers per 100,000. So it's a lot lower compared to all the previous examples we've been talking about, which is because of how our health system has been structured and how we have both healthcare in our regional areas and in our urban areas, and even in like our outback. So where there's still a high population, but it's very remote, you'll still be able to have very good access to services to some degree, which means that our country is very fortunate in this regard.
Yeah. So thank you, Jasmine. Really good point. So I'm parting few of the key terms which you have used, like access to care, having very good indicators in very low mortality indicators. So I will touch base that even within the high income countries and even in the lowest income countries, there are certain population where mortality indicators are good, and there are certain population in high income countries where the mortality indicators are as bad as any developing world. So so I will touch based on that in one of the video when I'll be explaining the vulnerabilities. Okay, so on the top of the list, Abdul, if you can share what you have identified. So I'm more interested now in what you have identified in terms of your country mortality.
Can you hear me?
Yeah, I can.
Well, in Panama, child mortality, it's mostly high in the indigenous communities. It is, well, it was more serious a few more years back, but it's still a serious problem, especially because maternity rate is high there because of teenage pregnancy in the indigenous communities. And it's mostly because the cultural background of them doesn't allow them to like go outside too much, and as well the government doesn't have like the willingness to go inside to develop a little bit more the healthcare inside. So the only way they can have a little bit of healthcare for their children is to go outside. And also they have other issues regarding the conditions of where they live that increase the mortality rate or the risk of having diseases, of suffering disasters, because most of the disasters here they happen in those communities which are more like apart from the rest. So that would be like the situation here. It's very similar to some of the countries that are in similar conditions to mine.
Okay, thank you, Abdul. Clifford, I'm sorry if I'm not pronouncing your name correctly, so sorry for that.
Yes, please, I've already presented mine.
Okay, yeah, you did that. Sorry. So Inas Amir, Inas.
Yes. So I think they already covered everything in the first three questions. Because like I can never come with a new list, for example. But for like the third question, the major causes for child mortality, I'm currently studying in the family medicine that the major causes are mostly the lack of access to healthcare and the ignorance of the family. So they just don't know how to deal with the child correctly. And also the sanity of the environment he's living on. For example, if he's living in a rural area which is highly condensed and contains a lot of pollution, he'll be dead. Also, about the diseases, they're mostly pneumonia and diarrhea. And for the last question, the maternal and child mortality in each.
Ines, I can't hear you, probably some connectivity issue. Probably she has left. Yeah. Ines, you can put those figures in the chat with the name of your country. Okay, so next, Georgius. Oops, Georgius has also left the room. Okay, Meher Banu. Meher Banu, you are here? Okay. So you can type later when you are free from CPR about the country mortality. So definitely rest of the question are pretty much the responses would be the same, but you can type. Okay, who else? Roxana? Roxana, please.
I'm really sorry, my internet connection is bad. Should I speak now or it's?
Yeah, you can. Yeah.
Okay. So regarding the maternal and child mortality in Egypt, actually it developed a lot since maybe the 1970s or something. It was really bad before. So now the maternal mortality is 37 per 100,000 live birth, declining from around 57 in the early 2000s. And for the child mortality, it's around 19.5 per 1,000 live birth, which is really high, but considering that it was 250 per 1,000 in 1971. So I think it improved a lot.
Yeah. Thank you, Ines. Georges, are you here? Victor? Victor, Winston, George. If you guys are here, so please, happy to hear from you guys. Happy to hear your voice. Okay, anyone else who haven't spoken yet, interested to share, and we all are happy to hear you and also the indicators for your country. Or you can type in the chat box now. That will be helpful. Okay, Georges, you can mention then in the chat box so that everyone will be looking at it. Okay, so thank you all for sharing whatever you have explored, which is pretty much close to or almost correct. Yes. So that will help us to move forward and understand next few information which we will be discussing during this session. So top 5 country for maternal mortality where the maternal mortality ratios are high. So these ratios are calculated based on, as I said earlier, number of births happening in particular country, particular province, district, or locality in a defined period of time. And then you also assess that how many women are dying during pregnancy, during childbirth, or next 6 weeks after the childbirth. So starting from the pregnancy initiation till the 42 days of post birth. So any maternal death during this period labeled as maternal death. So, and it's calculated against the number of births in a defined period of time. So top 5 countries are Sierra Leone, which has highest mortality, Central African Republic, Chad, Nigeria, and South Sudan has the highest maternal mortality. And then Afghanistan, Pakistan, India, they are also among the top 15 countries, top 10 countries. You can see here all the developing countries has the highest mortality, and mortality is even worse in low middle income countries. Why these women are dying? So most of the causes which are listed here, majority of them are preventable. You can see here the top contributor is hemorrhage, which is happening either during pregnancy or during childbirth, or postpartum, during the postpartum period. So most of the women who are dying of different type of hemorrhages. Then indirect causes. These indirect causes are not related to the pregnancy, but related to some medical condition of the woman, or some other infections which are not specific to pregnancy, but definitely women was suffering from XYZ infection, for example, malaria, for example, HIV, and or tuberculosis, that are not related to pregnancy, but she was pregnant and died because of that infection, but that maternal death labeled as maternal death because happened to be during pregnancy period, childbirth, or next 6 weeks of life. Okay, thank you, Mervano, for sharing the information. Yes, this is helpful. And yes, Iran has improved significantly its key indicator. And just for your information, Iran has one of the best primary healthcare system in the world, and especially in the developing, in middle income and low income countries context. So that's how Iran has reduced so much maternal and child death in last few decades. Then comes the sepsis, some other direct causes, abortion-related complication, and as well as embolism. So 99% of abortion which are happening across the world, especially in LMICs, low middle income countries and low income countries, they are all 99%, approximately 99% of them are unsafe abortion. And there are different causes why a woman seeking care to have an unsafe abortion compared to safe abortion. So it's depend on country to country level legislation for abortion, and a specific taboo attached to or stigma attached to attached to this abortion care, seeking abortion care, which is challenging in some of the countries, especially in Muslim countries, where there are some religious barriers pertaining to this. And then in some other direct causes which are mentioned here, which are nearly 10%, include obstructive labor and anemia. Obstructive labor means during pregnancy, there was some trouble in during the childbirth process, and child was not able to deliver on time, and it was prolonged labor, or the child was stuck because of certain medical condition or certain medical negligence. So most of these causes, these 10% of these causes, 95% or 98% of them are preventable if the health system is responsive enough to refer the woman or performs emergency C-section on time. But that's not an ideal situation in most of the countries, and that's why this percentage is pretty high, like 10%. And anemia, if you're aware, pregnant women in developing countries, they are also malnourished, and they are also anemia is also one of the type of malnutrition, which comes under micronutrient deficiencies. So still you can see on this slide that most of these causes are preventable, and that's where most of the country investment has been made to avert the risk of these causes. So all the key maternal, neonatal, and child health interventions, these are targeting to address these issues, to improve the care journey, to improve the health status of the woman, so that they can prevent these causes, can be prevented. And if you address the root causes which are leading to a specific cause of death, so you'll be able to address reduce the maternal mortality as well as some other poor birth outcome linked to that. Just given an example, that obstructive labor in most of the cases end up with stillborn child never born alive, and end up with intrapartum stillbirth, for example. Similarly, embolism may lead to stillbirth, sepsis may lead to stillbirth, hypertension may lead to antepartum stillbirth, like child born dead before the birth. So coming to child mortality, this slide is a bit complicated, but has very good information. And when you look at this slide carefully, you will know that where the most children are dying, why they are dying, and what progress has been made from 1990 to 2017. So you can see here all these countries, India, Pakistan, Nigeria, DRC, Ethiopia, they are the top countries where most of the deaths are happening related to under 5 children. And you can also see here that this light red is showing what was the situation back in 1990 and how much a reduction has been made in terms of child mortality in 2 decades, for example, from 1990 to 2000. So you can see here there are a lot of countries which has made significant progress. Look at this bar, this box for India, where 3.4 million children were dying in 1990. And in 27, it's 1 million. It's still very high, but there is significant drop in the child mortality. But at the same time, you can see Pakistan, compared to India, the progress is slow. The box is not changed much in last 20 or 25 years. Look at Bangladesh, significant progress has been made. Look at Nigeria, 1990 and 2017, almost the same. There is very less progress has been made in last 20 years or 25 years. Look at Ethiopia, it's still high, but progress has been made. DRC is stagnant, no change in the mortality. So this is what the child mortality looks like nowadays in this particular time period. So just for your information, in Asia, in 1990, 7.5 children were dying. Now it's 2.5 million children. That's each year. In Africa, 4.2. Now it's 2.9. So Africa compared to Asia, the progress is slow. There is a progress, but it's on a slow pace, and a lot needs to be done. And look at the South America, North America. There are very few children who are dying during the first 5 years of life. And we know that developing countries has a lot, has made a lot of progress based on what kind of services they are giving to the community, as well as some community related efforts which are grossly linked with education of the woman, health seeking behavior and all. So why children are dying? So what are the top causes? So you can see here the largest box, pneumonia, then diarrheal diseases, preterm births, neonatal asphyxia, other neonatal disorders, congenital defects, nutritional disorders, meningitis. So a lot of causes, but you can see here, these are the top preventable causes. Pneumonia, preventable. Diarrheal diseases, preventable. Preterm births, preventable. Neonatal asphyxia, preventable. So these top 4 causes, they are very much preventable. If I may ask, how pneumonia can be prevented, for example? Does anyone knows how pneumonia as an under 5 cause of death can be prevented? Any preventive way? Yeah, please, Enas.
Well, I'm not sure, but I know that there is an not mandatory vaccine for the pneumonia, which may be administered. Also, there is a classification, which is the red, yellow, and green thing for the symptoms, to just know where the child or the person in general lies in terms of the severity of pneumonia, and each stage is treated differently.
Yeah, so thank you, Ines, for your answer as well as highlighting this. So you can see here there is clear classification of neonatal disorders as well as child disorder. So here you will see a lot of all the red. They are the neonatal causes. As I mentioned before, 50% of the under 5 deaths, they are happening during first 4 weeks of life, like neonatal period. So neonatal period is defined as any child who is between the age of day 0 to day 28. So these are the key causes of death for that particular period. Diarrhea definitely happening when the child reaches certain age, when the weaning diet starts, or when the child exposed to external environment. So diarrhea is the one of the leading cause, and also the pneumonia. But these two causes, they are also linked with the neonatal period as well. There are children who are neonates and also died of pneumonia. There are children who are neonates and died of diarrhea illnesses. There are children who are 2 years of age, died of congenital heart disease, for example. So these are interlinked, but yes, clearly these all reds, they are specific to the neonatal period. And most of the deaths are happening because of these top causes, preterm births as well as neonatal asphyxia trauma. Pneumonia can be prevented, yes. As Inas mentioned, there is a vaccine which is called pneumococcal vaccine, introduced back in a few years back in most of the developing countries. I guess 2013 or 2012 was the period when it was introduced in Pakistan. 2012 was the period when it was introduced in Pakistan, and there are other countries which has rolled out introduced vaccine which we call PCV vaccine, pneumococcal conjugate vaccine, to avert the mortality associated with pneumonia. Some strain of pneumonia, not all strain, but some of the strain of pneumonia. And countries who have introduced this vaccine, the pneumonia related causes of death has been reduced significantly. And you can see here the drop from 1990 to 2017. And you can see there are some progress for diarrheal diseases, for preterm births, but not very much progress has been made in some of the causes. Then diarrheal diseases, they are also preventable. Hygiene, access to clean drinking water, and access to oral rehydration salt and zinc sulfate. And now vaccine is also available, like Rota vaccine. Rota is top among the top viruses which are causing deaths in the children among developing countries. So Rota has also made significant dent in these causes of deaths. So I guess, yeah, coming to preterm births can also be preventable when you address the maternal health and maternal nutrition, as well as when there is a proper birth order being followed. Like if the woman who conceived every year, the number of chance is high for preterm birth. And then also some other biological factor associated with preterm births, which can be prevented if implemented successfully. Yes, Cliff, you are right that personal hygiene and effective hand washing protocols are important. Yes. So and just for your information, these are the causes, but this nutritional disorder, or which we define as undernutrition, which is very common phenomena in developing world, where most of the children are malnourished. A specific type of malnutrition which they are suffering from is undernutrition. Like these children are stunted, low height for their age, either they are underweight, low weight for their age, or they are wasted, which means that their weight is less compared to their height. So when the child is malnourished, the chances of death chances of dying from these diarrheal illnesses, pneumonia, meningitis, malaria, or any other cause, or whooping cough, measles, is 50% higher if the child is not malnourished. So malnutrition play a very key role in increasing or decreasing this number. So remember this this thing. The child who is malnourished, who is undernourished, either the child is wasted or underweight or stunted, the chances of deaths become double. So that child is atomic bomb actually, and can die if catches pneumonia, catches diarrheal illnesses, catches measles. So addressing malnutrition is really a key in averting those risks, as well as reducing the child mortality as well as maternal mortality. So imagine if the mother is malnourished, undernourished, and she's pregnant, so she's not able to feed the fetus. The end result will be a low birth weight child, the child with low weight according to the week of pregnancy when the child was born. That child has at the risk of dying, risk of catching these causes. So whenever I used to train my health workers, frontline health worker, I always call a malnourished child a magnet who attract all these risks of dying. So remember this child, remember this thing, the child who is malnourished has double the chance of death because of malnutrition, as well as if catches those illnesses, these worsen the condition of that child and that child die very, very soon. So that's a key message from this slide. Okay, can you guys see this slide very clearly? The pictures? Can you? Okay, so sorry. So tell me what you are understanding by looking at these household structures. These are the three countries, and tell me what you're seeing. So one country is Rwanda, one country is Ethiopia, and second country is Ethiopia. So why I have chosen those countries, just giving you the background, you all know that these countries are facing some kind of disaster or conflicting situation. So tell me what you are seeing moving from here to here, and then from here to here, and from here to here, what you can see, and tell me why it is important for this topic. Any volunteer? Yeah, please, Cliff, go ahead.
Yeah, so for me, what I see is as the income per month increases, the household or the various house structures, they look nicer as the income per month increases. And that's the same for the three countries that's here. And how important is this to maternal and child health? Maternal and child health can be affected by diseases, and such diseases can be carried by vectors. So if housing conditions are effectively built or done in such a way to prevent such vectors from coming into the household, it means the mother and the child can be prevented, and there's also and with such a way to you're also preventing the transmission of disease from the mother to the child as well. So as the income of the various household increases, the risk of being infected with the disease also decreases, and maternal and child health also increases or improves. Yeah, thank you very much.
Yeah, thank you, Cliff. So just giving you elaborating what Cliff has said. Thank you so much for your wonderful points. So as I mentioned before, inequalities and vulnerabilities exist within the countries as well as between the countries. So you can see here between the countries, there is a lot of variation. You can see a household who is earning just $54 per month. And this is a poor country. Rwanda is poor country. The maximum income is $460 per month. So when you go from here to here, you will see that the vulnerabilities and access to different different facilities is improving. In this particular household, access to clean water, wash, like hygiene, proper toilet, food, it's very poor or probably very rare. But here, as you go further from this side to this side, the high income within Rwanda, so these people have probably proper access to clean drinking water, food, and other facilities. And same is the case with Ethiopia. When you go from here to here, lack of services, lack of access, improved access. Similarly, within the high income countries like Ukraine or any other country like Australia, as we were discussing with Jasmine few minutes back. So within the developed countries, there are inequalities exist. So if you ever have seen the slum areas in Baltimore, USA, you might have seen similar houses like this. And when you go to those particular communities in Baltimore or the slum areas attached to any other developed countries or the top metropolitan cities, you will see that probably they are living in a situation like this. So inequalities and vulnerabilities are associated with low income, poverty, you can say, low education, and lack of access to the basic of amenities to the life, which everybody should have access. But here in these particular household, people don't have proper access to all those facilities which we are enjoying as a person. So this is within the country comparison. But look at this household, which is high income in Ethiopia, and compare it with these two and this in Ukraine. So high income in the lowest income country is far worse than the lowest income household in a developed country. So this is what inequalities are. So this household or similar households probably have higher mortality even compared to the lowest income household of developed country. But when you compare the Ukraine highest or any developed country highest income household, the lowest has poor mortality compared to the highest. So this is a fact. When you segregate the data of Australia, USA, Italy, where I'm sitting right now, there are households which has the worst mortality than the country reported mortality. For example, Australia has the child mortality of 3, I guess, correct me if I'm wrong, Jasmine. There are some communities, some immigrants or some household where the child mortality is probably not 3, probably it's 10, 12 or 15. There is a chance, because not every single household or the locality can be at the same mortality level. Everyone has different mortality based on their inequalities they are facing and vulnerabilities which they are experiencing. Now, in the next slide, you will see the household and the families, and you can see how they are different. So this was the lowest income household of Rwanda, highest in Rwanda. What difference you are seeing here?
The number of people.
Yes, number of people, because the lowest, the poorest you are, the poorest access to the care and the basic, but you can say the healthy behavior, the poorest access to those behaviors you have, or the worst behavior you have. So in why the poor countries or the developing countries have highest population? Because most of the people, they have high number of children compared to high income countries where the number of children is still low, even if they are not earning well. So the more poor you are, the more number of children you have, the chances of death is high. So malnutrition, pregnancy related complication, child mortality, it's high in this particular section of the population. And as you go towards this population, it's decreased. But because this country is overall poor, the chances of deaths still remain high. But not here, mortality will remain low compared to this particular household. Similarly, here less, here high, here less, here high. But when you compare from here to here, here to here, here to here, this whole section will remain at the highest proportion of deaths. So this is how we define vulnerabilities. And when you are planning any maternal and child health related intervention, can you then apply the same rule for all the groups? Can you? Can we do that everyone? Yes, there are certain things which everyone should have access, equal access, but there are some key intervention which should be targeted for those where the vulnerabilities and inequalities exist the most. If you're not able to do this, you will not be able to reduce the child mortality and maternal mortality. Am I clear on this point? Please do mention if I'm not clear. Yes, no? I'm taking it as a yes now. Okay, so I'm now showing you 2 videos which will give you some idea on what we have discussed so far on the vulnerability, child mortality. So give you some good idea.
How many people live in cities? Look, Total world population is 6 billion. Half world is urban, 3 billion lives in cities. But out of these, 1 billion people lives in slum. About the future. In the year 2050 here, experts predict that world population growth will stop at around 9 billion people. 6 billion will live in urban area. The open question is, can slum be made history?
You guys cannot see the video? Sorry.
Yes, we can only hear, but we can't see the video.
Wait. I'm sorry for that. Can you now?
Yes, please, you can.
I'm sorry, I'm not able to make it full screen because it's showing an error. So you can see this.
How many people live in cities? Look, total world population is 6 billion. Half world is urban, 3 billion lives in cities. But out of these, 1 billion people lives in slum. About the future. In the year 2050 here, experts predict that world population growth will stop at around 9 billion people. 6 billion will live in urban area. The open question is, can slum be made history? What does it mean to live in slum? United Nations Habitat Program has a clear definition. Slum is the failure to meet one or several of 5 basic needs. Number 1, every family needs a durable house that can withstand a rainstorm. Number 2, everyone needs sufficient space for their family so that every member have a place. Number 3, families need secure tenures. They must have the right to their home and they must be protected against sudden eviction. Number 4, every family needs safe water that doesn't transmit diarrhea. And finally, number 5, safe sanitation. That means everyone needs some sort of a decent toilet. But now, let's follow the real experts. We shall listen to the slum dwellers themselves, how they explain these 5 basic needs.
This is somebody's house. The way it has been built is not that good. You can see for yourself.
My house. I sleep there. We are 7. Some are sleeping here.
We believe that soon or later, this will be history for the people living, for the slum dwellers, and for the people who are poor. The roof, as you can see, is not that well. The water just get inside as if there is no roof. This is also somebody's house. The wall itself was curtained. There's no even iron sheet in the walls. We used to live in this house, but after flood, we shifted. There was a house constructed at this place, but they were swept away. We would like, and we are really hoping to see one day when things are changed and when this slum will no longer be a slum.
That morning, we just saw a tractor coming, and we were stranded. What happened? We stood aside to see what these people were doing. They had told us that they will evict us from here, but we were not believing it. Now it happened that day came and everything was being demolished. So we had no alternative. Just stood aside and saw our things, our properties were demolished and everything was removed from this place. So we had to look for alternatives, and I had to move from here and look for another house somewhere else in Kianda area.
Poverty is too much. People are not having jobs. Sometimes I do wash clothes for people, for my neighbors, and I get a living. If I get some money, I pay for the house rent. If I get some money, I do some, we make some food and eat. But really, it's very difficult for a woman like me.
This is the only son I have. Ellie, Kate, and she's Esther. And I have my beautiful girl, Sophie, come. I have my beautiful girl, she's called Sophia Aquino Kate, the first born. And I have another one here, it's called Melvin. And at this time now, he's on medication. You see how it is. All the loose people are doing, the flying toilets, the whatever, they're throwing them and then they're coming here. Now I'll show you how the toilets are. And these are the tools, you see. These are things people are doing and then they're coming out, doing like this, and they're going even up to the house. You'll find all the people who are coming from this place. They are diarrheaing because of the kind of situation. My hope is that she is going to be fine, and I know she's going to be well. You know, to feel better.
Shaka sawa sawa wewe, pamoja na wewe, rafiki yangu wewe, katika safari yangu tatembea na wewe, pamoja na wewe, pamoja na wewe, katika safari yangu tatembea na wewe. Basi kutaka ili niheshimiwe, nayo nikute mashaka sawa sawa na wewe, pamoja na wewe, pamoja na wewe, nikute mashaka sawa sawa.
Solution indeed is what this agency is all about. You know, we are not here just to cry over the problem. We're actually every day looking for solutions. And first of all, the first solution is awareness, because this problem, many people are not aware. You know, people are not aware of the magnitude of the urban challenge. So we are urging member states, nations, communities, local authorities. We work very closely here with local authorities to invest in the slums, to upgrade slums. And now we are even assisting member states to prevent slums, because the reason slums also are mushrooming everywhere is because there is no planning. You don't plan adequately for these people. So if this is recognized, then we feel that we look for solutions. Solutions, of course, is about planning, about democracy, about solidarity, and about equality, equity, to make sure that you invest into the urban poor, that you see these people as an asset rather than a liability.
Let us follow Anna Tibajuka's advice and look at the global challenge, the magnitude of the global challenge. And this chart here shows you all the countries of the world. Each bubble is a country. The size of the bubble is the population. The red bubble down there is China. Now, the color of the bubbles shows the continents. You see the green is the Americans, blue here is the African, and so on. Now, what we are showing here on this axis is the percent urban population of the total population. China here is below 20%, and here it's 60%, and so on. It's easy to understand. On this axis down here, I show economic level of the country. Gross domestic product per person in what is called purchasing power parity. That is the comparable value of the currency of the country. Now, let's look at the situation in the world 1963. Those countries who had the lowest economic level had very little people in the urban area, living in cities. And those countries which had best economy, they had more people living in the urban area. But there was quite a variation, Let's look at which one is which. Of course, Singapore is up there. Singapore, everyone lives in the city because it's a city nation. Whereas United States had about 71% of its population living in urban areas. And now I would like to show you the change. How has the world changed from 1963, 64, 65? As we move on here, you can see China and India are now having economic growth and people is moving into the urban areas. In the 80s, most of the country bubbles are moving up like this, and more people live in the urban area. Look here, 2002, 2004, that's where we are today, the latest statistic available. And it's interesting to see that in the world today, the Americas, if I mark the American countries, those are the bubbles here. This is Brazil and Mexico. They're very highly urbanized. The whole of Latin America, very highly urbanized. All countries is above about 70% in urban areas. Let me show you the Arab countries in the Middle East. Also, the Arab countries are very highly urbanized, and so are the European countries. In fact, it's only the African countries where we find a low degree of urbanization together with the countries in Asia. The light blue ones here is South Asia. Those bubbles here, that is India and Bangladesh and Pakistan. Most people still live in rural areas, 2004. And even in China, look, this is China. Even in China, we have 40% in the cities and 60% still in the rural areas. So what Anna Tibajuka means with the urban challenge, there's no doubt that the billions of people which will be added to the population in China and India, they will be added in the urban areas, in the cities. And a large part of these people living in the rural areas, they will move into the cities. We can really see on this map that what has taken place in Europe and in Latin America and in the Arab countries, that will also take place in East Asia, in South Asia, and eventually also in Africa. We are facing an enormous urban challenge, but it's also an opportunity, because in cities it's easier to provide school and health service. And also working opportunity and economic growth is there. And a healthy growth of cities can mean a healthy economic growth for rural areas.
So you guys have seen this video which talks about is exactly the same thing which we were discussing, that how vulnerabilities has been defined. And in the changing world, when most of the rural population is moving to the urban areas, that's where the rural population settle in urban slums. And urban slums are the areas which are deprived of most of the civic amenities, basic health facilities, have highest mortalities, have poorest indicators. So that's where the child mortality and maternal mortality is high in those countries. So this is exactly what we have discussed in the picture. If anyone has any questions, so I'm happy to respond. Then we can move forward. Okay, so just a small video which also talks about the child mortality. So it's a very short video which I would like you guys to see as well.
My father told me about 50 years ago was a divided world. It looked like this. Each bubble is a country. Size is population. Blue, Africa. Red, Asia. Yellow, Europe. And green, the Americas. Vertical is child mortality. From 30% of children dying before the age of 5 down to almost 0 child death. Horizontal, number of babies born per woman, from 8 to less than 2. But most countries were up here. Women had 6 to 7 children. Child deaths were frequent. Almost every family lost 1 or more children. In many people's mind, the world still looks like this, developing and developed. But it's a myth, because the world has improved immensely in the last 50 years. Here we go. Year by year, child mortality fell in almost all countries. And as child mortality fell, women chose to have fewer and fewer babies. And that enabled them to invest more time and resources in each child. By 1990, some of the so-called developing countries had already made it down here. Some were in between, and a few remained up here with very high child mortality. Ethiopia had hardly moved at all. It had passed through decades of famines and political turmoil. Many people think that Ethiopia is still stuck up here, But look what happens after 1990. With improved access to health service in rural areas and well-spent aid, child mortality falls dramatically in Ethiopia. And with better access to family planning, women choose to have fewer and fewer babies. Ethiopia has come halfway and is moving quickly down to this corner. But Ethiopia still faces many challenges. I will split the Ethiopian bubble. The capital, Addis Ababa, is already down here. But the remote Somali region of Ethiopia still have high child mortality. But most of the regions, 90% of the population, are centered around the average. Most people think that the problems in Africa are unsolvable. But if the poorest countries can just follow the path of Ethiopia, it's fully possible that the world will look like this in 2030. Then there will be no countries left in the box we once called the developing world. But to ensure that that happens, we must measure the progress of countries. It's only by measuring we can cross the river of myths.
Okay, so this is what we touched based in one of the previous slides that, sorry. Okay. Technology. So in one of the previous slide that this is how mortality looks like, and within each country there are some disparities and there are some significant improvement which you can compare with any developed country. So every region, every specific community has different different challenges, different lacking, based on which the number of deaths and number of child deaths and number of maternal deaths can be defined accordingly. So sharing my presentation again, where it is. Yeah. So this is what all the key global partners, WHO, UNICEF, and the individual governments have signed this this pledge that by 2030 they will reduce the maternal mortality by 70 and child mortality by 12 per 1,000 births. So that's what they have committed so far for 2030. But as I mentioned before, there are some countries who already reached this target, like Australia and any other developed country. And there are some countries which are still struggling to reach this level of mortality and reach this mortality level. But these targets are set in Sustainable Development Goals. So, okay. So when we're talking about this universal health coverage concept, this maternal and child health related interventions and mortality, there are a few key things to deliver at community level. If community don't have access to those services, those infrastructure, you're not able to attain reduce the child mortality and maternal mortality. And the key concept is to allow people to access universal health coverage. Like whoever you are, wherever you are living, you have access to universal access to the basic healthcare services without any financial hardship. So this is a key concept which has been introduced in last few years, that every country and within every country, every community has access to quality health services without any financial hardship. And how they can be assured that this can be done. So it's through health system strengthening. If you have proper governance of the health system, like medical staffing, their proper some monitoring and evaluation of their services, their performance, continuity of care, equity, quality, responsiveness, efficiency, and resilience. So this is how you will be able to achieve universal health coverage, and you are able to achieve all the key sustainable development goals which are in place to reduce this maternal and child health related mortality. So all the sustainable development goals, they are grossly linked with universal health coverage, and they are standing on the health system. So without having all those principles in place, you're not able to achieve maternal, neonatal, and child mortality. So MNCH in emergencies. Remember one thing, in emergencies, the maternal and child health remains of grave importance. Their vulnerabilities, their inequalities can never be changed. Even they can be worsened in all the emergency situation, whether it's conflict, whether it's natural disaster, floods, earthquake. So all the key causes of deaths which are associated with maternal mortality and child mortality, they remain the same, or they even get worse. So understanding this key concept that even in the disaster, the prime importance should remain to reach to those particular population sections where women and children are being affected. So just giving an example that 1 in 5 women of childbearing age, they're likely to be pregnant during emergency. So it's a high number. And 500 women die every day due to complication related to pregnancy and childbirth in any emergency situation. So these are the key things which when you are in your next level of career, entering into choosing the field of disaster medicine or humanitarian aid, just remember this thing that women and children remain of significant importance and being most vulnerable and key to address. So when we talk about pregnancy care or any child health related or maternal health related care, remember this thing in the mind, this model in the mind. They're always when you dig down the causes of death, you will understand that apart from the medical causes which we have discussed, the obstetric care, for example, the root cause is just associated, linked with these one of the or some of these delays. Why we are calling them delays or delay model? So when you look at any care seeking or any health access to healthcare, there are 4 key domain of access. One is pretty much linked with the seeking care, like at the family, at the household level. One is the second is reaching to the care. Third is receiving care, and fourth is continuing care. So when you have blockade at any of this level of care or any of this level, it end up with the maternal or the child death. So addressing those issues in a real world context as well as in the emergencies is the key thing to be considered. So remember these things, that every particular delay or domain of the delay has certain factor to be considered and to be addressed, issue associated with those factors to be addressed. So just giving you one example, that care seeking at household is pretty much linked with condition of the household during emergencies, for example, demographic factors, socio-cultural factors to seek care, patient-related factor, whether woman or the child is injured because of some disaster or similar kind of calamities, service experience during disaster, or financial factor which probably been worsened during emergency. Then we discussed this a little bit, the concept of undernutrition. When we talk about MNCH, apart from this delay model, another thing is is malnutrition, which we have discussed, that if a child is malnourished, if the woman is malnourished, the risk of dying becomes double. So just giving you an example, that the countries where most of the women or children are dying, look at those countries. They have the highest undernutrition rate. The underweight means low weight according to the age. The child should be at certain level, but the weight is not optimal. So that's where most of the children are also dying. Like, see this dark orange color, where 70% of the children are less than of their optimal weight. And that's the reason why most of the children are dying in those countries. Nutrition in emergencies, we need to look at what are the nutrition level in particular community which is under disaster. So the key thing is to understand the basic concept of acute risk of acute malnutrition, worsening of the situation, which is of the existing condition, which is chronic malnutrition, or any micronutrient deficiencies. And when we talk about nutrition in emergencies, so remember this thing, the vulnerable group affected the most, and they are the people who are the risk of developing this undernutrition. So addressing those key areas and looking at those key areas carefully is the key to avoid any risk which is associated with the undernutrition during emergency, which then lead to high mortality for maternal and child. So when we're talking about nutrition and emergency, so every humanitarian organization always look for these two key indicators, which I don't want to go in detail, but just for your knowledge, that they look at acute malnutrition rates in the community or the severe acute malnutrition. So I'm not sure if you any of you have ever been exposed to the real world context where frontline health worker measure the mid upper arm circumference of the mother and children. So this gave you the clear idea that how many children are malnourished in particular community in disaster or in any emergency situation. So this give you measuring the mid upper arm circumference of the child and the mother, give you the idea that whether the child or mother is malnourished or not, because there are certain cutoffs to define this this acute malnutrition. So as we discussed, that there are communities who are poor, who are living in urban slums or in rural areas or in poor areas. They are the most vulnerable and at the risk of developing nutritional undernutrition, and then a risk of deaths become increase as well. So everything is linked with their physiological vulnerability, geographical vulnerability, where they are living, any oppressed population, for example, refugees, or is there is any internal displacement happen because of certain conflict or certain disaster. So these four vulnerabilities define the risk of the population of becoming becoming malnourished, and then God forbid the mortality related risks as well. Then coming to another key concept of maternal and child health, we touch based on pneumonia vaccine and also that rota vaccine to avoid the risk of pneumonia as well as diarrhea. So immunization, imagine, is the most cost-effective intervention ever been done to avoid the risk of child deaths as well as maternal deaths. But there are in most of the countries there are at least 15 different 12 different antigen which are being introduced in last 2 or 3 2.5 decades. Like most of the countries have rolled out their immunization program back in 1975 or early 80s. So to introduce the vaccine against the most lethal diseases which causes the child deaths. So unfortunately, most of the countries where most of the children are dying have the lowest immunization coverage or missed out children. So you can see 101 million children in India and Pakistan are still unvaccinated. They haven't received a single dose of diphtheria, pertussis, and tetanus, which are the most lethal diseases, but still children are being left out. And that's the reason why these countries have still highest mortality, highest number of deaths. So here you can see just unprotected children, which are never received their vaccination. So there are 20 million children still in across the world, which never received the vaccine. So, and you can see how many children in Pakistan are unprotected, for example, how many children in Nigeria are unprotected, how many children in these top 10 countries who are contributed the most to unvaccinated children. You can see the burden, and these are the countries where definitely the mortality burden is also high some way or another way. Also, what happened during emergencies? So when any emergency happened, so most of the services which are pertaining to maternal and neonatal and child health, they are disrupted. Just giving you, this slide is giving you an example what happened during COVID pandemic. I'm not aware, I'm not sure how many of you have heard that because of COVID, when COVID happened, there are a lot of services which were suspended. There are a lot of services which are diverted from primary healthcare to COVID related response. So when all this happened, there are a lot of countries where immunization services and other primary healthcare services were either disrupted, suspended for a longer period of time. And you can see here, the red countries are those where most of the immunization campaigns which were supposed to be happening, they were suspended because either staff was worried to catch the infection or to expose to COVID infection, or services were diverted, or resources were diverted to some other programs, for example, COVID immunization or COVID related emergency or hospitalization setup. So this is what happened during emergencies, and this is what the thing to be worried, that when emergency situation happen, and if you don't have a clear plan, a clear response, or the robust response, you end up with neglecting the most important services. And that's where you introduce the double or triple burden on the indicator like child mortality and maternal mortality. For example, just clearly mention here that due to COVID, measles vaccine or the campaign related to measles were suspended. And imagine the child was not died of COVID, but end up with the measles related death because child haven't received the measles vaccination. So when we talk about emergencies, universal health coverage, the universal health coverage, which talks about all the key services pertaining to maternal, neonatal, and child health, including nutrition, pregnancy care, avoiding delays, avoiding disruption in vaccination services. Countries should have a proper, a robust, resilient plan in place, in which they can address all the key barriers which are linking to disruption of the services or inaccessibility of the services. So for the continuity of the care, whether it's emergency or non-emergency situation, having a proper preparedness plan in place is the key. And this all come from understanding of the key vulnerabilities at the community level, key hazards which this community can be exposed to, and also some social protection mechanism in place for those communities, so that you can have a robust plan in place, so that if any emergency is happening, you are able to sustain and continue those services without any disruption and without any bad thing to happen especially for those mother and children who are exposed to this emergency or disaster situation. So UNICEF and WHO and other partners has defined the term minimum initial service package, that in any disaster situation, what should be the key package to be delivered for mother and children to continue the services for mother and child. So in any emergency situation, these adequate diet, iron, folate, or nutrition supplementation, immunization, malaria prevention, access to care, birth preparedness, healthy timing, birth spacing, hand washing, deworming, and access to maternal health services is a key. This is a key for maternal and child healthcare, regardless of having emergency situation or not. But in emergency situation, this become even more important. And similarly for child related care, post-birth, or you can say during when child is born, or any under 5 children, exclusive breastfeeding and appropriate breastfeeding is important. Essential newborn care is important. Hand washing with soap is important. Appropriate complementary feeding is important. Adequate iron and nutrition supplementation, vitamin A supplementation, zinc and oral rehydration therapy, prevention care for malaria, full immunization for age, prevention and care seeking for acute ARI, the respiratory infection, and deworming for 12+ months of children. It's the key package which WHO UNICEF is recommending in any emergency situation, that this is a key package when any disaster is happening or emergency situation happening. This should be the key services which should be available all the time to mother and children. So what is preamble during disaster and emergencies? We know that these events happen all of a sudden, and they never gave any pre-information so that one country can be ready. So the key thing is to identify the risk factors which require rapid assessment and understanding of that community where this disaster or emergency situation has happened. Also identify key health condition of the population which require possible intervention to be rolled out, or some targeted intervention to be implemented. So whenever you being exposed, being in future, being an humanitarian or disaster aid staff, you've been exposed to or being sent to any of disaster or emergency related area, just remember that these are the key points to understand what information you need from that particular community, how you can assess the community needs, also what data is available on ground from those communities, just to understand the community specific needs, as well as key indicators which are already there with some governmental program or some local health facilities, for example. So what are the guiding principles during emergency and disaster? According to your current knowledge based of certain situation, you always align these key points that, as I mentioned before, that understand the community, and you can label that community with the high need, with the medium need, and with the low need, and then plan your intervention or your response accordingly and according to the need of that community, so that you can make a visible change or visible impact on the maternal and child health related mortality. Okay, some experience from the COVID. What happened when this COVID arrived? And we all know that services were disrupted. So you can see the MNCH related sustainable development goals were affected the most. So people are saying that decade of the progress on reproductive health, maternal health, and child health has been stalled or reversed. I have seen one of the recent report which has been published today by UNICEF and WHO. The immunization rates has been dropped significantly compared to last 1 decade progress. So this is huge impact of COVID which we have seen. And why this happened? Because of poor response at the country level, poor preparedness, and diversion of the services from primary healthcare or from MNCH to the COVID related response. So when this all happened, now we are seeing the bad results out of it. So remember this thing, the response and the country preparedness for the emergency or any community preparedness for those emergency is the key, so that you not end up in diverting or suspension of the services, rather continuing those services, which ultimately benefiting those mother and children, women and children in the communities who are the most vulnerable. So I'm concluding here my session here. I'm happy to hear from you guys. If you have any questions, remarks, comments, please do share. And then we have a very small exercise to do once we're done with the Q&A. So please go ahead. G, yeah, please, Adil, go ahead.
So it's not a question, it's more like a comment. I like how like you gave different approaches of the reasons of or the main, like the main points, the key points regarding maternal and child health, because normally we'll see like only one picture or one side of the coin, saying it in that way. For example, I didn't see like how much the living conditions were a factor in these cases. I knew obviously like the nutrition and the immunization cases, and that has something to do. It's very, I would say, obvious, but some other things that we don't see like
on from the outside. So yeah, was very interesting.
Thank you. Thank you. So any question, any comment, please do share. Happy to hear from you guys. So if none, I would like to share with you one small exercise, which initially I was planning to do in a 2 breakout room, but as participants are just very like just 19, is it okay with you guys if you can, I can leave for 10 minutes, giving you the exercise, what you need to do, and then you can one or two of you can just present instead of doing it in a breakout room. So I guess it's more of discussion, keep it more of discussion. That will be good. So exercise is related to, again, humanitarian context, that you are project lead and you've been assigned a task with the mission moving to a country which is hit by an earthquake of magnitude 6.8. What baseline information of the population affected by earthquake in order to understand the specific need related to MNCH? How do you prioritize the needs? I mentioned here divide into 2. So whatever comfortable with you, just let me know. If you want to do in a 2 different groups, I'm okay. If in a single group you want to discuss, that's also okay with me. What do you think? So I can then do the breakouts then. No, I don't know how I am not able to make the breakout room. Can you guys still look at the screen? Yes. Okay, someone has suggested if you can divide. So let me do this breakout thing. I don't know why I'm not able to do this breakout thing. Just a sec.
Hi, sorry, I disconnected. Can you add me to a breakout room?
Hello, I get disconnected. Can you put me in the second group?
Okay. So welcome back. I'm happy to hear from you guys. I don't want any presentation. It's okay if you, but happy to hear from you, from each of the group, what you guys have discussed and what you have came up with. So please do share your thoughts and your discussion points. So group one, please. Can be a single person who can take the lead and then rest can discuss, or whatever convenient for you guys.
Hello.
Yeah.
Actually, we didn't get a chance to discuss because most of the group, because of the disconnection, we left the room, and by the time we got back in the room, most of the time was we lost most of the time. Yeah.
Okay, no worries. But what do you think as a basic, as per the basic understanding, what should you consider for as a maternal health intervention in such kind of disaster? What are the key things which you need to understand from the community viewpoint?
The question is the first one was what baseline information do we need to understand to prioritize the needs. So I think we need to know the demographic of the population, the estimate of the mothers and the children, and how many of them are displaced, and etc. Also, I think we need to know the health facilities capacities, especially after the disaster. How many health facilities are there, and if they are working. Also, the intervention programs that already exist.
Mm-hmm.
Okay. Yeah, that's what I think about the baseline information.
Yeah, these are all good and valid points. Anyone else who can add more from group one?
I could add that since it is a disaster that happened or an emergency, the resources are limited, and of course we can't take all the resources regarding maternal health, but it's still important. So yeah, I agree with Ines about the demographics. That's an information we need to know, because in that way we know how much we need to focus on, for example, in this case, maternal health, and that way we can search for resources that are still available for us. Obviously, the ones that can be more useful, I think the ones that can be more useful in this subject, like in maternal health, should be used in maternal health interventions, because yeah, it's important, and as well they will be like more effective being used for this.
Yeah, valid point. Thank you. Anyone else from group one? So yeah, as Inas and Abdul has mentioned, these are all the key points to be considered during any of such situation. And also from maternal viewpoint, another key aspect to know from the demographic, apart from demographic information, how many of those women who are displaced are pregnant. So that's another important thing, because few of them probably be delivering in next few days, and access to a proper skilled birth attendant is the key to save both mother and child. So just wanted to add. And then obviously the nutrition and immunization services for mother is also the key, because and one another key point is providing a woman who are being displaced a kind of shelter where she can breastfeed the child if the child is on exclusive breastfeeding or under the age of 6 to 24 months. So that's important aspects which one should consider while thinking for maternal intervention during a disaster like this. Okay, so over to group 2. Please, anyone of you can speak of child intervention. That would be great. Come on, guys. Group 2.
Hello.
Don't be afraid. There is no right or wrong question, and I'm not going to mark you on this. So please feel free to say whatever you have in your mind.
I mean, we really didn't get the chance to discuss, but I'll try to, like, I'm gonna try to say something.
Yeah, sure.
I think basically we have first, of course, know the number of children and divide them into their like specific age groups. And then in order to prioritize their needs, we need to focus on what they lack the most. So are these children mostly injured and do they need like clinical interventions, or are and of course children need psychological support in these times as they are one of the most vulnerable groups regarding mental health. And also we need to like connect them with sources of information, such as if they're missing their parents, if they're missing their family. And also I thought of like these children will eventually like if their schools are demolished, they also we need a way to keep them learning. So I've seen such and I've seen it that some tents and really basic teaching tools can be employed in such disasters.
Agree. Anyone else who want to add?
So I just wanted to add on to Natalie's point in that whenever an earthquake happens, so we've read this in like community medicine that there are increased chances of airborne infections like various fungal infections and various bacterial spores can, be aerosolized and then be inhaled. So the chances of children not getting enough nutrition during the disaster, and at the same time, the aerosolization of all the microbes, the different fungi, and at the same time, the disruption of the primary healthcare services in the community can actually aggravate each other and make this like a really challenging thing for us as healthcare providers to kind of intervene them in making sure that they don't get infection. And if they are having some sort of an infection, then we can treat them properly because, again, as Natalie said, children are very vulnerable portions of the society. So I think keeping an eye out on even the smallest of infections can be useful to kind of stop a local epidemic of some sort.
Agree. So thank you all of you who have contributed. So almost all of your points are are genuine and valid for situation like these disaster for both for mother and children. So remember the key point that why these women and children are dying. So we discussed that most of the causes are preventable, and these are all the preventable causes are low hanging fruits, we call, like can be easily addressed and can be easily being accessible, like services to avoid those causes can be easily accessible. So whatever you are planning, you should keep one thing in mind, that these intervention should target the root cause for all the key preventable causes. Like if the woman is pregnant, identify a pregnant woman, link them with the services. If the child is coming to center, give them vaccine, screen them for nutrition status, give them nutrition supplement. If the child is under the age of 6 months, counsel the woman for provide the psychological counseling as well as counseling support or breastfeeding support to the mother so that she can continue breastfeeding. Because in disaster like these, the very first thing happened because of some cultural barriers and religious barriers, women stop feeding their children because they're being exposed to the outer environment. So these are the key things which we should keep in mind to understand the situation and planning best for these communities. So with this, I'm happy to conclude. I hope I didn't bore you much because topic is, yes, I understand it's complex, but I hope that you guys have developed some knowledge. Definitely you have the previous knowledge, but I have added some few more to your knowledge. If you have any questions, so please do discuss. My colleague Farman is here who will now take the next session. So I will then leave. So if you have any questions, please do ask. Otherwise, I will leave.
Hello, Yazir. Here I am. Thank you very much for your super interesting session. I am sure that the students enjoy it.
I hope.
Yes, yes. I'm sure. So thank you very much. As always, I remind the students that they can ask anything on the platform. So if you have any questions about a single lecture, I will then forward this question to the lecturer. So if you have some thoughts about this session, use the platform, and then Yazir will reply as soon as possible. So now Farman is here for the next session, but I suggest to have a short break since you had more than 2 hours super intense. So if you agree, I would say to reconvene here in 15 minutes. What do you guys think?
Okay, guys, in the meantime, I'm leaving. Take care. Bye.
Thank you, Yazir. Thank you so much. Thank you. Okay, guys, so what about reconvening here in 15 minutes at 3, let's say 5 minutes to 4?
Yeah.
Great. Okay. So in 15 minutes we reconvene here. So some minutes before 4 o'clock Italian time. Okay. So Farman, are you okay with that?
Yes.
Where are you? Yes. Okay. Great.